My topic today is evaluation of acute and chronic ischemic heart disease and echo complications of acute MI. As you can tell, it's a pretty broad topic, but I've tried to touch into main points, especially for the first part of the presentation, which is evaluating acute and chronic. But really, and then the second part of the presentation is pretty heavy on the complications of MI. And I have a format where we can first show, an echo complication, then people give a guess at it, and then we'll kind of get into some specifics. That's the CME credit statement for those who need it, and I don't have any disclosures. So my presentation is divided into like 3 sections. We'll go through some introductory points, some specific echocardiographic techniques, and then the complications. So part of the introduction will cover pathophysiology, the coronary territories, and the appropriate use criteria for echo in ischemic heart disease. So the left side of the screen shows, the common pathophysiology for what leads to heart failure. And really, there are a lot of insults to the left ventricle, and coronary artery disease is one of them. So there can be others, including, cardiomyopathies and valvular disease. But the point being that once your ventricle gets injured, there is remodeling of the ventricle, which leads to low EF, your symptoms, and it kind of sets off a cascade of neurohormonal stimulation and endothelial dysfunction, eventually, leading to pump failure, death, and arrhythmias and other complications. On the right side of the screen is this famous, graph that shows how changes occur during ischemia. And as you can see, systolic dysfunction is actually pretty early. So you see systolic dysfunction even before you see EKG changes or symptoms like angina. And even before that, you'll see diastolic dysfunction, which can be a little hard for us to take by the bedside. But if you pay attention, the kind of x-axis is duration of ischemia in seconds. So we're talking within beats of ischemia, you're going to start seeing wall motion abnormalities. So such a good tool for us to use by the bedside when we go for these STEMI calls so that we can assess any wall motion abnormalities, especially when the picture is a little blurry. So some pathophysiology specific to acute MI, it results from a disruption of a vulnerable plaque, kind of triggering a clotting cascade, leading to intravascular thrombosis and subsequent hyperperfusion, leading to cell death, apoptosis, and necrosis. So this is a diagram for those of us who use first aid for step 1 that kind of goes through the basic physiology, the basic changes in the heart with MI. And as you can see, there is early coagulative necrosis, which eventually causes this area of weakness within the heart, eventually leading to a scar. But what I'd like to point out is that 0 to 24-hour period and that 3 to 14-day period is really where most complications occur and are your highest risk for watching out. If you pay attention to the 3 to 14 days, this is where the body is trying to heal this area of ischemia. So it starts forming like a soft kind of regranulation tissue before a full fibrous scar is formed. So this is the time period when your heart is most susceptible to some of the mechanical rupture related complications. And the first 24 hours is more related to, cardiogenic shock, pump failure, arrhythmias, those kind of complications. On the other hand, stable ischemic heart disease is really different. You should kind of think about it in different terms. It's not plaque rupture. It's more just kind of progressive stenosis due to stable plaque, which eventually gets calcified, leading to remodeling and chronic hyperperfusion. And really, it's that the chronic imbalance between oxygen demand and supply, which can be picked up using different modalities of testing, which we will get into in a bit. But that can lead to some chronic scar formation and ventricular remodeling, again, as I mentioned, and also its own kind of realm of valvular dysfunction, which can need separate treatment if indicated. And that's where we start talking about stress imaging, from coronary CTs to stress echoes and other modalities like MPI. That's where all of that becomes relevant. And I'm going to try and keep everything kind of focused to our echo modalities today. The third concept, the third concept to keep in mind while exploring, all the echo modalities we get into is coronary territories. It's kind of like our basics of LV function assessment. So as you can see, the areas of blue are highlighted by the RCA LED is in light green, and circumflex is kind of like a shade of pink. So circumflex, like you can see, can be hard to pick. Even on EKGs, it's notorious for hiding. And so not surprisingly, even on echo, it can kind of overlap territories with the LED and the RCA. So that can be hard to pick. But in general, the LED covers the anterior wall and part of the anterolateral wall and the septum as well. And the circumflex covers the lateral wall, and the RCA typically the inferior wall and the RV. But there are exceptions, especially when you have several collaterals, chronic occlusions, or a left dominant system. That's the appropriate use criteria for echo. Which there were like at least 10 pages of appropriate use criteria for the use of echo, and I try to highlight the more important ones that I felt are relevant, but there are several indications. You're almost never wrong to do an echo, except these two circumstances when you're absolutely sure it's an ACS. You see a clear STEMI. Basically, what they're trying to say, if you don't have access to an echo machine, it shouldn't prevent you from going ahead and getting. Obviously, if you have a bedside echo, go ahead and do it, but it shouldn't delay care. And the other time is you probably don't need an echo if to have a stone cold normal EKG with exercise testing and with a very low pretest probability. So those are, barring those two exceptions, two extremes, it's probably okay if you get an echo. So coming to the second section of the presentation is what techniques in echo can we use to evaluate ischemic heart disease? Now, as you can see, we're dealing with two different conditions, really, acute ischemia and chronic ischemia. So I'm going to kind of lay out everything and then kind of highlight which can be used when as we go. So 2D echo, that's our kind of the first line thing that we're going to do. It's going to help us assess chamber size, systolic function, and wall motion abnormalities using those areas of description that I had before. And from our 2D echo, we can gather a lot of information. So first, any LV dilation or worsening EF, especially less than 40, has been linked with worse outcomes. And there's been studies over 2 years, they have worse mortality and worse survival rates. The next thing you want to pay close attention to is enlarged LA volume. So this is also related to worsening 2-year outcomes, especially when the LA size is more than 32 mils per meter squared. And the last thing the echo is going to help us with is assess recovery over time. So this is especially relevant in stable ischemic heart disease. If someone had an AMI and post-intervention, you're kind of assessing their refunction in a few months. The second part of the echo that's helpful in assessing ischemic heart disease is valvular function. Now, the most common valve kind of affected with MI or ischemic heart disease is the mitral valve, barring effects from annular dilation, things like that. But the mitral valve is directly related to worse outcomes in ischemic heart disease, and especially when it's moderate to severe. So a study showed patients with an ERO of more than 20 millimeters squared tend to have worse 2-year outcomes as well. But it's also important when we assess these, we can term it ischemic MR. It's also important to assess these ischemic MRs in the light of, how much preload and afterload are affecting the MR. Now, there'll be a lot of cases you see when, if the patients are on a ton of pressors, the MR just looks worse. And the minute you take that away or once you initiate GDMT, everything starts to look better. So it's important to evaluate these ischemic MRs in a setting when your preload and afterload has been optimized. And really that's the, how it happens. That's the kind of mechanism of how ischemic MR results. So once you have LV dilation, the papillary muscle kind of pulls onto your valves, leading to a lot of tethering and tightening of the cords, which has most effect on the posterior valve, because as you can see, this looks pretty tight, but also on the anterior valve. So the anterior valve starts to open while the posterior valve stays a little static, and that results in MR. Now, you can have both eccentric and concentric MR. So that's not necessarily a criteria to determine which kind of MR will result from an MI. So if you see an MR in the context of an ischemic heart disease, you should evaluate and optimize the preload and afterload. So this is hanging a little bit. If you look at the top left, it might be a little clearer here. The posterior valve just kind of like stays in one position while the anterior valve is trying to do all the work, and eventually resulting in like this posteriorly directed MR. So this is typical for an ischemic MR as well. And as you can see here, a lot of these patients, this can progress to severe, and that becomes important because that can be if they're symptomatic with dyspnea, chest pain, or whatever it is, or fatigue with exertion, they may need additional treatment with intervention such as a mitral clip or something. But you want to make sure you've optimized your GDMT and ensure they don't have the severely hypertensive while you're getting these measures. The other important part in this would, as we know, in assessing MR would be the heart rate. The next kind of echo tool that we use is the wall motion score index. Now, the utility of this is mostly limited to like a research setting, but some people do use it, and it has shown to have some correlation with outcome. And really what it is, it's a summary of your wall motion scores across all segments divided by the number of segments. So as you can see, a normal is 1. So if you take all your segments and if they all have normal function, your wall motion score index will be 1, which is normal. So if you have an index of close to 2, like a wall motion score index of more than 1.8, it's shown to have a linear relationship with mortality and survival. So it is an important tool that can help you assess outcomes. The last would be, we mentioned diastolic function is actually one of the early pathologies that occur from ischemic heart disease. And what's been shown is a deceleration time of less than 140 and an EE of more than 15. So that has been linked with worse ischemic outcomes over time. And all these kind of hint to, how well your medications are working and whether you need to do anything additional to support their heart failure care. So where does kind of stress echo fall under this whole realm of ischemic heart disease? Really, it has no utility in the acute setting, so we should stay away from it. Unless you have a patient admitted and you're just not sure whether this is ischemic heart disease or not, then it may have some role, and you can get information relating to the EF as well. But mostly for stable ischemic heart disease or progressing, especially with symptoms, so worsening dyspnea, worsening chest pain. And there are different modes of stress we can use. Exercise is the preferred mode. And usually supine bicycle has been shown to have a slightly greater sensitivity than kind of treadmill stress. And for pharmacological, dobutamine is preferred. There are other agents such as vasodilators like dipyridamole or adenosine, but dobutamine can help you gauge the response at low stress and high stress, and we will just get into that, how that's going to help you determine things like viability. So what are our objectives with a stress echo? It's to look for inducible ischemia, especially with peak stress. You're looking for new areas of wall motion abnormality. And that can be very subtle and hard to catch. And we'll look at maybe a few tools that can help you gauge or assess that when you're not able to do it with your visual aids. And then the other thing would be a contractile reserve. So a patient may look like they're hyperkinetic, but typically with like some low dose of dobutamine, they start to have better response. And that can be indicative of viability of that tissue in the heart. So that's what we typically phrase as a biphasic response, where when they pre-peak on a low dose of dobutamine, they have improvement in function, but when you hit a high dose of dobutamine, you start losing function. And that actually gets a class 1 recommendation for testing during dobutamine or bicycle stress test to determine viability and ischemia. So here's an echo. As you can see, the top left is normal, like at baseline. And then this is on low dose. I think to my eye, at least, it looks like this kind of inferior wall is starting to kind of come in a little better. While at peak, you kind of see it lose its function right here again. And then this at post stress, it's back to its baseline. So this is a very typical feature of a biphasic stress test, which should be helpful in assessing viability and ischemia. And where does strain imaging kind of fall in its utility. So we all know strain. I feel like every VA echo gets a strain too, but if done correctly, it's got a lot of value, and it's actually been shown to be an early marker of dysfunction even before we can pick it. And this is just like a bullseye diagram to show you the territories involved for LAD, RCA, and LCX. So like you can see anterior wall, kind of that inferoseptal wall, and then LCX with a lateral, inferolateral territory. And a normal global longitudinal strain is like about negative 20%, and this is reduced with ischemic heart disease. And it can help detect before we see any regional wall motions. Its use in stress is helpful because some studies have assessed how does your wall strain change with response to any stress. And it should improve to above minus 20%, which has shown to have better sensitivity and specificities compared to just visual assessment. So it goes from about 70% to 80%. And when you combine that with the wall motion score index, the sensitivity is close to 100. So you're more likely to pick any kind of underlying ischemia if you combine these modalities. We all know DEFINITY, and we kind of like, oh, I wish this had DEFINITY, but I think our group does a great job of giving DEFINITY. And the utility is greatest when we use more than two segments are not visualized. And that data comes from this study that assessed the use of DEFINITY in stress images. So they assessed the confidence in interpretation when readers were able to visualize two or more or two or less segments. And as you can see, they felt a lot more confident here. But less than that, it really doesn't make a difference. And then it helps tease out any subtle wall motion and obviously helps with thrombus detection, which we'll look at. So this is a stress test with the use of contrast imaging. I'm going to highlight this. I want you to pay attention to this. This is peak stress without DEFINITY, and this is peak with DEFINITY. As you can see, it's a little hard for us to tease out very clearly if there's any kind of wall motion or not. But when you give the DEFINITY, that kind of wall motion abnormality becomes very clear. So go DEFINITY. So that kind of brings us, those are all the tools we kind of use, whether mostly, as you can see, the tendency is once patient has had an MI or once, if we're assessing their kind of stable ischemic risk, those are the tools that we're going to use to assess their risk, impact and survival and such things, and whether we need to add any therapies or not. The next part of the presentation gets into the complications of an acute MI. I kind of touched into this a little earlier, where I talked about how the first few hours are especially more vulnerable to like ventricular arrhythmias, cardiogenic shock, and complete heart blocks. They're kind of very like physiologically driven complications. While 3 days to about 2 weeks, 14 days, is when the heart is most risk for mechanical complications, and that's due to that incomplete scar formation, and that leaves them at risk for things like ischemic MR, like papillary muscle rupture, VSD rupture, VS rupture, LV free wall rupture, and then later on they can have symptoms for like pericarditis, which can have associated effusions and such things. So kind of the main complications, I've just kind of listed them out here. And as we go through the images, not in any particular order, we can give a shot at what we think is happening. So the first thing, within 24 hours, this patient has had a STEMI, pump failure, EF is like 10, 15%. That in itself is a complication needing intervention, such as, we may need balloon pumps, impellers and such. That's very important to recognize. And usually they come to the CCU and we're able to have them on the heart failure service. RV infarct kind of gets its own class because they tend to be hypotensive and they need kind of urgent intervention, and we'll look at reasons why. And then abnormal regional wall movement is something I put as a complication post-MI, because there are some wall motion abnormalities that deserve particular attention. which we'll discuss. We talked about LV thrombus. It's important to distinguish aneurysms from pseudoaneurysms, and we'll look at a few images there. Pericardial effusion and what that means and when do we really care. And then a VSD rupture and a papillary muscle rupture. So in no particular order, we're just gonna kind of go at this. If anyone wants to give it a shot. Yeah, I think it's the most kind of evident, at this base inferior wall, and then probably the most evident here. You have this kind of basal septal region. So most likely an RCA infarct, and the patient ended up getting a stent to the RCA proximally. And this is so echo has great sensitivity to pick transmural MIs up to 100%. So if you see a wall motion abnormality that's obvious, and they go into the cath lab, like there's a very high chance you're going to see an MI, like an acute occlusion. However, like for non-transmural MIs, which are mostly subendocardial or mild to moderate ischemia, it's highly variable. And in some studies, it's even as low as 0 to 10%, but a pooled analysis showed its sensitivity is up to 80%. So still useful, but you can't rule out ischemia if you don't see wall motion abnormality, basically. And especially that becomes of low utility when only less than 5% of the LV wall. So, we're talking things like very distal MIs that probably are going to get missed on echo. And then wall thinning or lack of systolic thickening is kind of what we look at to assess wall motion abnormality. And the challenges with this is there are other issues that can there are other conditions that can lead to segmental dysfunction, such as a right bundle branch block or RV pressure and volume. And honestly, other things that will even raise troponins like myocarditis and Takotsubo. So it can be very hard to differentiate what's MI versus, what's an underlying myocarditis versus Takotsubo. So you really have to take into account their clinical presentation. And a lot of times you have to do a cath to rule things out, but especially if they're stable. This is kind of the next complication, so to speak. Without having you like hunt for things, it's really just pump failure. So cardiogenic shock with like a massive LV with very low output, probably call that EF close to 10. The one thing we would worry about is, looking out for any LV thrombi. So pump failure occurs in about 10% of all MIs leading to cardiogenic shock. And it typically occurs when you have more than 40%, so almost half your myocardium is involved. So we're talking big arteries like, prox LADs or prox, or like a large circ, rarely a large prox RCA as well. So those would eventually lead to pump failure. And risk factors are, involving territories of the left main, LAD. If the patient has underlying multivessel disease to begin with, and then one sustains a plaque rupture, a history of a prior MI, and early use of beta blockers. So I know there's, there's this whole kind of thing, when do we use beta blockers? But really, if they're cardiogenic shocks, you should avoid using beta blockers because that's what sometimes the heart rate is all that's kind of driving the cardiac output. This is a cascade of events that, just in an MI leading to systolic dysfunction, hypotension with initial compensatory vasoconstriction, but really and then systemic inflammation kicks in because you have peripheral cell death like necrosis leading to cytokines, and eventually that also causes vasodilation, further ischemia, and eventually progressive dysfunction and death. So once you kind of enter the cycle, you almost definitely need some kind of mechanical intervention with a balloon pump or an impeller. Any thoughts here?
RV.
Yeah, so the RV looks massively dilated. And if you pay close attention, there's also like the McConnell sign. So you have apical hyperkinesis. So you could argue in the right setting, this could very well be PE, but an RCA infarct can give you a very similar appearance. And if someone's presenting with chest pain and you have ST elevations, that should raise red flags. And what you would see on an EKG is, with your ST elevations and leads 2, 3 and AVF, and in your inferior leads, and a lot of times the lead 3 ST elevation is a lot greater when the RV is involved. So typically this is a proximal RCA infarct, and about 4% of them can be from a left coronary system. So we talked about, either a collateral circulation or a more left dominant circulation. And these are the things you kind of see on your clinical exam. They're pretty hypertensive. They've got a JVD, but you assess their lungs and other markers of what would typically be associated with LV dysfunction, and that's absent. This reduced, and usually the reduced RV function leads to reduced LV preload, eventually causing the hypotension. So they are great responders to fluids, especially in that early setup, when a lot of remodeling hasn't taken place. But kind of in the later part of the MI, they might not tolerate volume very well either. So they do need emergent reperfusion, and volume isn't the only thing you'll do for them. But you should avoid diuretics and nitrates. We talked about that. Some other, that's just parameters of RV dysfunction. So we're talking about TAPC of less than 16, S prime of less than 10, functional area change of less than 35. And you'll typically see a dilated IVC. So very, it kind of looks like PE really, but if you see your ST elevations, you're with a chest pain, you're leaning towards an MI diagnosis. Any thoughts on this one? Yeah, perfect. So I hear apical aneurysm, and you kind of look at that area, and we'll look at I think Dr. Beaver gave a recent talk, a conference on differentiating aneurysm from pseudoaneurysm, and that's very helpful for this talk as well. You can also see the apical wall looks pretty thinned out, so that's important to note because some aneurysms can pose risk for rupture, though it's rare. And if you don't ignore that, that kind of stands out, and that's your entire heart, and that leads to this kind of passage into here, and that becomes more evident when we put on some Doppler. So it can be important, and these are great images, but sometimes it can be hard to see where the neck is, because I can just imagine a situation where if you're a little off axis, you're not able to see the true neck, and you end up calling this aneurysm. But it becomes important to use the additional tools like color Doppler and even contrast. Sometimes that can help look at the flow into the pseudoaneurysm. So important to distinguish between aneurysm and pseudoaneurysm. So just a random spot question. So which one has a narrow neck? The pseudoaneurysm. And typically the ratio of entry is 50%. If your entry point into the aneurysm is less than 50% of the maximum cavity diameter, then you're more likely to call it a pseudoaneurysm. But these are suggestions, and you're not hard and fast rules, because with a remodeling of the heart, some aneurysms can start looking like close to pseudoaneurysms. I think Dr. Beaver did show one of them last time. Which one involves all 3 layers? And that becomes important for risk of rupture. So the aneurysm is basically the heart remodeling and not, scarring out. So it's kind of, and what really a pseudoaneurysm is a contained rupture. So you think of it like all the 3 layers of the heart are separated, and the only thing keeping that rupture in place is your pericardium. So the one that involves all 3 layers, I guess it depends how you look at it, involves not for the tear, but involves in terms of the aneurysm, would be the aneurysm. And then which has a higher risk of rupture? So with only 1 layer protecting it, the pseudoaneurysm poses the highest risk of rupture. So even though pseudoaneurysm is this outpouching of the heart with the pericardium kind of protecting it, it's got no myocardial tissue, so there's no change in myocardial structure. But aneurysms, on the other hand, kind of thins out the entire area of the myocardium, leaving them at a higher risk for VTs and especially like scar arrhythmia and things like that. While because an aneurysm kind of leaves a greater space for them to, have stasis of blood and accumulate clots, they have a higher risk of thromboembolism. So even though pseudoaneurysms can lead to clots, a higher risk for thromboembolism is really the aneurysms. That's that's a diagram to kind of help differentiate the two. As you can see, more likely to have a mural thrombus in true aneurysms in the infarctus segment. And in terms of management, pseudoaneurysms is an emergency. If you see a pseudoaneurysm, they're very high risk of rupture, and usually you want to manage them surgically. While for true aneurysms, you give it time medically, unless they have high risk features like progressive heart failure or VT or worsening angina. And that's just to kind of highlight, we all know DEFINITY and how well it does to highlight some, unclear images for LV thrombi. And here's one pretty obvious one, which you could probably catch in a bedside echo, but it's due to slow static flow in the area of akinesis and typically in your apical segments. There are cases when other segments can be involved, but most are in kind of your apical regions. And it's usually associated when your EF drops to 30% or below. There is a risk of thromboemboli, and we talked about the role of contrast enhancing agents such as DEFINITY, which increases your sensitivity from like 30 to 60%. So here's a patient with an MI who we did a bedside echo and noticed pericardial effusion. Anyone with thoughts? I guess in my mind, as I was looking at this, I'm like, okay, like what are high-risk features? What starts to worry me if I do this echo in a bedside?
Bleeding into the pericardial space.
Yeah, so there is this, we call this coagulant. There's this kind of like accumulation of blood, so to speak, in your pericardial space, which can by in itself cause chamber collapse and features of tamponade, even though the effusion size, it's still large, but you can have a relatively smaller effusion, but with a lot of coagulant, just restricting mobility, and the heart just cannot move. So if you see that on an echo, that is a high-risk feature and is very suggestive of a free wall rupture. And you should especially start looking for this when you see effusions of greater than 5 millimeters. And if you see a coagulant, that should be very concerning. And again, it's very hard to really see that area of rupture on your 2D echo. It can be frequently missed. It's usually not spotted, but sometimes you can use contrast to kind of see if there's any movement of contrast between your chamber spaces and within your pericardial space. So this is the actual image. It's kind of like slowing, but weird. But I think you can still see what I would like to show you. And this is a kind of zoomed in image of the septum. Kind of giving it away when I say it's a septum. But yeah. So that's a VSD rupture. And if you look carefully, the LV kind of heads into the RV space and forms this kind of route. It's not like a direct connection, but because it's just all debris and necrosis, and so it will just find a path, any path it can use, either for rupture or through a VSD rupture. And that becomes more evident, that kind of path we were talking about, on echo Doppler. Now, the challenge with this is, you can tell, when this should be easier to spot, but in more subtle cases, it can confound with like in TR tracing. And so you've got to be a little mindful of what you're catching and where, and really look, especially if the patient is very unstable. You should be looking for a VSD rupture if you don't see any other obvious causes. It is rare, but it can happen. 0.2%, typically in that 3 to 14-day period, like we talked about. But all these numbers, are done from studies in the 90s, where like we really don't have information in this kind of, 90 minutes door to balloon time. So we have a lot. Things have changed, and newer studies are showing all these complications that we're going to talk about, including mechanical ruptures, can occur within the first day. So you should always have a high index of suspicion, especially if your patient is unstable, because these have high mortality rates. You can see mortality is close to 50% with surgery. So without surgery, it's close to 70, 80%. So it's and what we talked about earlier, free wall rupture has a mortality of close to 80%. So if you don't intervene, there's a chance that they will not survive. And we say early intervention. The thought was a little different earlier. They would actually leave VSD patients without any repair, and they kind of leave it to see if they make it, and then if they're stable enough in 2 to 3 weeks, try to repair it. And the reason for that is what we talked about. The tissue is just so like friable, and it's like not, you can't suture through it. So you would kind of leave for some scar formation so that you're able to do it. But more and more studies have shown the sooner you intervene, the better.
Ladies.
There are newer options for repair, including VSD occluder devices, and the location of the VSD can help you decide. Usually basal VSDs are not good for occluder devices, but if you have an apical VSD, that can be fixed in the cath lab with a VSD occluder device.
What's going on, Marlene?
Any thoughts?
No.
Oh my God, Sally's here also.
Yeah, so as you can see, the anterior wall, the anterior mitral valve just is moving freely between the ventricle and the atria. It's just kind of flopping. And that's typical for a papillary muscle rupture. And you see the same here as well. It's just kind of moving back and forth. And you have, in most cases, like torrential MR to pay attention to. And here we see, it can involve both valves too, both leaflets. So it is important that even though we recognize that one of the leaflets can be involved, but a lot of times it can be both leaflets too. And typically the papillary muscle that's involved is the posterior medial. And the posterior medial papillary muscle attaches to both the anterior and the posterior leaflets. So it just depends on where the rupture occurs, which can cause your echo changes or the mechanical changes. The other thing you see with torrential MR, when there's almost equalization of pressures between the LV and RV, you typically want to see this well-rounded, MR waveform on continuous Doppler, but you see this cut-off sign, which can be indicative of severe MR and showing early equalization of pressures. So what do we see here? This one's a little, I didn't see it right away. I was like, what are they showing? But until they showed me the bottom left, right? So as you look at this images, you can see there's a high velocity across the LVOT. So there is LVOT obstruction. And if you look carefully, the aortic valve is barely opening. And what's happening here is you have a hyperdynamic kind of base with SAM. If you look during systole, the anterior mitral leaflet moves forward, and that kind of creates all kind of turbulence in your LVOT tract. So again, index of suspicion is kind of what leads you to these diagnoses. And they intervened and noticed that things just improved. The patient was requiring higher pressures, higher and higher pressure support, and even needing a balloon pump. And eventually they intervened and everything came out. And the intervention really is to just reduce your afterload. So they ended up stopping all the inotropes and depressors, especially inotrope, because that will lead to a hyperdynamic basal LV. So you take those out, and the base of the LV starts not being hyperdynamic. You give them fluids. You have to be careful, minding that they're not in cardiogenic shock, but that eventually helps relieve that obstruction. They said even balloon pumps, like, you probably want to take them out because that can be contributing to this dynamic LVOT obstruction. So really, I just put them in a class of valvular pathology with papillary muscle ruptures. Rupture, which occurs typically within a week post-MI, involves the posterior medial muscle, usually with an RCA or a circumflex infarct. either or both leaflets can be involved,
It's very
leading to the
unpredictable
typical,
when
med school teaching is that they present with acute pulmonary edema and shock, and that's when your suspicion is highest.
it's very unpredictable. Sometimes
And the repair of a papillary muscle is incredible results, right? So it's very comparable to a patient who just had an MI, which was fixed without any complications. So once you see a pap muscle rupture, you want to get your surgeons on and get this repaired ASAP. On the other hand, for SAM, again, high index of suspicion, especially if you start seeing high increased velocities, usually seen with this hyperdynamic base and akinetic apex. Again, as part of our differentials, Takotsubo can look very similar, and we have a very kind of similar treatment or intervention plan for them too. And usually associated with anterior MIs where the apex is not moving, but the base of the LV is hyperdynamic, that can lead to SAM and LVOT obstruction. So we do try and avoid inotropes for them. This is a good summary slide that shows all kind of mechanical complications, at least that we talked about, from dynamic LVOT obstruction to a VSD rupture, RV infarct, pericardial effusion with suspicion for pre-wall rupture, a mural thrombus, a true aneurysm in itself, which increases your risk for a mural thrombus, a pseudoaneurysm, which has a very high risk of rupture, a rupture itself, and then a ruptured papillary muscle. And overall, even though we've talked about all this, the most common cause of cardiogenic shock post-MI remains pump failure, right? So that's always going to be like the main thing that you consider and you treat. But if you're running out and you've started patient on all kinds of interventions, you've done everything, and you're just not able to figure out why, you got to look closely. And all these other complications, even though 5 to 8% range, for that patient, that's what's happening, and you've got to find modalities that can help you figure. It is operator dependent. We talked about that. Not all patients have good acoustic windows, and that's why we use things like strain and strain not so much, but more contrast. False negatives in early ischemia or small infarcts. We talked about how strain imaging can help, but when you're doing a bedside echo, you probably might miss an early infarct. Not an early infarct, or small or distal infarct with a territory that's hard to describe. And it can be hard to differentiate between an ischemia, an ongoing ischemia versus a previous infarct. So again, your clinical presentation is what drives most of the things. Those are my references. Thank you.